So, Corey, any other interesting combinations that you'd like to comment on?
You know, we've concentrated certainly with the TMB analysis on CTLA-4 inhibitors with PD-1 and PD-L1 inhibitors, but there are many other agents out there. Ben alluded earlier to the potential benefits of angiogenesis inhibition, and there have been phase 1, phase 2 studies now looking at pembro with ramucirumab. In a relapsed population, folks have been platinum exposed with response rates in the 30 to 35% range. Now, granted, it's not the 60% we're seeing frontline, but it looks better than that 16 to 18 to 20% response that we typically see with single agent IOs, and tremendous interest, of course, in moving that forward to the frontline setting. Individuals are 50% or higher to have total equipoise, putting patients on that sort of trial. We've seen similar data from Tara Gandhar, who's really a melanoma expert, but looked at epacadostat, an IO inhibitor, an IDO inhibitor with pembrolizumab, again with a 35% response rate. There have been negative data in melanoma, but I caution our routine extrapolation from one disease to another. I think these agents really need to be studied separately. And similarly, there have been studies of necitumumab now with IO agents, again generating response rates of 30 to 35%. So the door is wide open. And of course, there are a whole fleet of agents, other immunotherapy agents that can be combined with these approaches. So both in the second line setting and potentially in the first line setting, the door is wide open.
And I think the door is wide open. I'll just say one thing, some of these combinations are rooted in some biological rationale and some of them aren't. And I'm actually okay with that. I mean, I think, and I've said this before, we're in some ways throwing darts at a dartboard and seeing what sticks. And I think that's what we have to do right now. I mean, the only problem is we have so many trials with perhaps too few patients. And I think we need to be mindful of which trials really have some strong scientific rationale and which ones maybe don't. I think that's important to consider, but the door is open. I mean, I think we're going to learn a lot. The observations we're going to witness from these trials may feed back on some basic science research, and I think that's important.
Right, and just to continue on that theme, it's also about trying to find biomarkers. And that is going to really be crucial as we move forward, because talking about cost, we want to make sure that the drug, remember, not everybody benefits still, the curves still go down, particularly the PFS curves, all right? So we really do need to try to find better biomarkers so that we can individualize treatment so that when you're spending the money, you've added value overall.
And that will help drive down cost as well.
Exactly.
And I agree. I think particularly if we look at small cell, if this pans out, about a third of patients with small cell seem to have very high TMB, and which is no surprise considering their smoking history. And their Ipi-Nivo seems to have had particularly high response rates, PFS and OS. So is there a way to really identify those folks who are going to be on the tail of these curves and not expose individuals who are really not going to benefit?
Well, yeah, that's it. I'm going to have to revise my saying. I've always tried to be the teacher of we want to get the right drug to the right patient at the right time, revise it at the right cost.
That's good.
Yeah, to do that. Well, I'd like to thank my colleagues. This has been a very informative discussion. I hope helpful to you. Thank you all for your contributions to all the discussions. And on behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.